Alright, hi guys. Welcome back to chapter 50 in Lewis Medical Surgical 12th edition. This is part of the same exam review for the first and second exam. So take a moment to appreciate the meme of the day. And let's continue. So first things first when talking about renal issues is that there's some basic terminology that you should be aware of and know what they kind of mean, because if you don't really know what the test question is asking you, then it's kind of hard to answer the questions. So very briefly, I'll kind of describe each one. ATN is just basically the ischemia due to either lack of blood flow and the tissues inside don't get enough nutrients. It can also be due to toxins and other stuff. Glomerulonephritis is basically anything that ends in itis is indicative of inflammation, and this is talking about the glomerulus part of the kidney. Azotemia is basically the accumulation of waste products that are high in nitrogen. So azo is like the root word for any nitro-based kind of products. Oliguria, oli meaning few, urea meaning urine, so small amount of urine in a time period. So overall, in a day, you're looking at this 100 to 400 ml mark. The general rule of thumb is 30 ml an hour, or if you're being more specific, 0.5 ml times the patient's weight in kilograms. That's also a good way. That's like the more accurate way to figure out the amount of urine that the person should be producing. And anuria, just basically an meaning nothing, so no urine output at all. So some studies here. We have the first one, creatinine. This is the waste product when the body breaks down muscle tissue and digests protein from food. Normal ranges include 0.7 to 1.2, but once again, go with whatever your professor is saying. BUN, it's not BUN, BUN. Urea nitrogen is a waste product that's created when the liver breaks down protein during digestion, and it gets filtered through the kidneys, and it's a range from 7 to 30. Again, the ranges are usually not the highlight of these exams and like the key points for NCLEX. It's more that when you're checking renal studies, you're checking creatinine and BUN for kidney functions, okay? Like how well it works. GFR, glomerular filtration rate. Sorry, it's always a hard word for me. It measures how much blood they filter each minute. Some things like the age, the gender, and also the ethnicity can affect this number. The next one is urine specific gravity, USG. It's talking about the concentration of urine. Okay, so it usually has this range on screen 1.010 and 1.030. The bigger the number means that it has more particles in the urine. So you can think of it has more stuff. There's more solute, right? Because pure water has the density of 1.0 flat, so urine just has a little bit more than pure water. And if it's on that 1.01 side, it's less dense. There's less solutes, so it's generally more clear, more diluted, basically. Don't forget about urine analysis, and we're going to talk a little bit about things to look for in the UA, like the color, ketones, bacteria, just like on this slide here, hemoglobin, pH, specific gravity, which we just talked about, crystals, sediments from kidney stones, which we'll talk about as well. Ketones is pretty important for DKA. Okay, so now we're going on to UTIs. It's generally split into two different sections with the upper tract right here. There's this pyelonephritis, meaning like hot kidneys, and then cystitis, which is cyst basically is the root word for bladder, and then there's also urethritis, which is like the urethra part getting inflamed. Okay, but it's mainly just these two right here. So when you're looking at a UTI, like this is a slide that generally has all this information, and you're thinking, how do I read my professor's slides? The way I like to do is I just like to group these things up and see how to clump them together for easy memorization, right? So this you can easily clump into age. So what age group is at risk, right? It's these newborns, pubertal children who generally don't have the best hygiene, right? Like little kids, they don't really do that well. And obviously older adults often come with UTIs, probably the number one reason they're brought in from sniffs to hospitals, right? Then there's also like feminine care and women's health. So the pregnancy status, people that are being treated with antibiotics that disrupt their flora, and then obviously using things that aren't recommended, like for example feminine sprays, right, spermicidal agents that are harmful, bubble baths, right? And then lastly, I like to group this up in like basically like a disease or a condition, right? Because if you have like diabetes, HIV, you know, an obstruction, these are all things that can contribute to an infection. And once you think about it, like logically, you're like, oh, that kind of makes sense. The only odd one out is HIV, but if you have like any experience like in the hospital and heard about like any blood exposure things, like one of the things like doctors will do to check on you is to like kind of like palpate your renal area in the back, and then they like the colicky pain, they will assess for that, and that's kind of like one of the things they do here. Also habitual delaying of urination, like the nurse's bladder, because you know we hold our pee because our shifts are so busy. That's another way to get UTIs. So CODIs are definitely the most common health care, like, you know, associated infection. The number one suspect for these infections are E. coli, this bacteria, and then Pseudomonas as the secondary species. Doctors need to know this a lot better and more in depth than nurses do. We just need to know that it's generally like microorganism related, and the fact that most of them are kind of under-recognized, under-treated, and leading to extended hospital stays, which jack up the increased care of health care, like the cost, and then the patient's morbidity and mortality. This slide is pretty important when I was in school because my professor really wanted us to know like what are the reasons when you would place a catheter, and like she basically taught it as like if it's not for one of these reasons, your patient doesn't need a catheter, which I agree with, because the catheter shouldn't be placed just for our convenience, right? Like in a perfect like, you know, world, you know, these are the reasons why you would place a catheter, because you are putting them at risk. I think there's a study that like says like after a month of leaving a Foley in, it's like basically 100% chance of getting like, you know, a UTI. So you can take some time to like look at like, you know, retention, needing accurate eyes and nose for surgeries, or like for example giving birth, this one like a C-section, healing in the wounds that are like in the sacral area or the peri area, prolonged mobilization like after and like an MVA, like motor vehicle accident, and an end of life, you know, care for comfort. Because I remember my professor's face saying that she's like, it's just to make them nice and comfortable. But yeah, it's true. I would write this a couple of times if you need practice memorizing these, but these are pretty important. So obviously the best thing to do is kind of like abstinence, right? To prevent a CODI is like if you don't need it, don't use it, right? Like kind of in that sense. But also if they do have one, it's important to do proper catheter care. For example, at like hospitals, they do like once a shift, you know, or like, you know, with like these little easy clean wipes, like that's the policy that they have. And obviously encourage hydration of the patient, right? Because you want them to just urinate and try to flush the bacteria downstream and not let it fester in their bladder. So, you know, once again, cystitis is down here in the bladder, and we mentioned that earlier. They say it's the most common site of the UTI, which does make sense because it's like one of their, it's like ascending upwards from the site of where you're urinating. It's like, you know, it's much harder to reach your bladder, I mean your kidneys than your bladder, right? So, yeah. Signs and symptoms, like any of these changes to a person's urinary patterns, like feeling this burning, painful urination, increased going, a malodorous smell, you know, and this colicky pain that you'll often see in like the questions of a short answer, or like a, or not short answer, sorry, like a prompt of a question, like the STEM will say like this patient's reporting colicky pain, right? That's probably one of the ways you can think a UTI. So diagnosis wise, it's symptoms, where you can do UA and then do a culture, right? You can do the clean catch, or you can take it from the Foley. And then, like I said, my professor was big on imaging studies, but I did not think it was very important at all. Like for the NCLEX. For her exams, yes, but for the NCLEX, no. Like we said earlier, promoting adequate intake is helpful in the interventions, because you do, like, if they drink more, they'll pee more. Hopefully, like that's the goal. If there's nothing wrong with them, like in terms of retention wise, it'll flush that bacteria out. You want to have good I's and O's to make sure that they're actually peeing everything that they drank out usually. Obviously pain meds, catheter care, and then obviously education, right? Like for example, practice good hand hygiene before you like use the bathroom and after, just good things to do. Some things you want to evaluate for, right? Temperature, because with fever, like usually a sign of infection. With elderly, you need to be careful, because sometimes they won't present with a fever because their normal body temperature is a bit lower, so just keep that in mind. Assessing their voiding symptoms, pain, more UAs, and obviously white blood count in any sort of infection. You can see the trend of it going down, and up and then down as it, the infection is resolving. That's pretty much it for UTIs. Now we're going on to kidney stones, okay? So kidney stones are also known as calculi or urinary stones. They're usually a mass of something. It's usually protein, crystals, or any other substance that can form, and it basically essentially blocks the urinary tract, like from the kidneys, the ureters, down to the bladder, right? Like anywhere in that period, or anywhere along the tract, it can block it. Okay, some risk factors. Obviously, age, gender, race, what you eat, occupation. These are some common ones. So for kidney stones, the risk factors: consuming high amounts of oxalate or purines. If you guys recently did anything related to gout, this should come across as like familiar stuff to you, because these kind of go similarly hand to hand, not like perfectly, but it's kind of related. Hypercalcemia and hyperparathyroidism with the increased calcium, because of the relationship that they have. I mentioned it in my electrolyte review, which is one of the first videos I have. And then any blockages of the urine that makes it like the urine to be in stasis in the body, you're going to have like a higher risk of like these stones forming, because it's not moving. And immobility is a big one. Problems absorbing the oxalates and stuff is also another one. And obviously if you drink a lot of Celsius or energy drinks like I do. Kidney stones, the signs and symptoms, like basically the manifestations, you're going to have this renal, ureteral, colicky pain. It's usually in the back side, not on the front. And when you pee, you have like these changes to your urine, like painful urine, bloody urine, and even sometimes retention, because if the stone is like blocking the tract, you might not be able to even pee out anything. So this is just like pain, right? And then these are urine changes, was how would I lump them up together. Diagnostic wise, it's basically just like ultrasound and imaging and tests, right? Like the urine analysis to determine what is in the urine, if there is any urine at all, right? You can see, is it like oxalate, citrate, or whatever else it is. Treating the kidney stone, a lot of it is like pain relief. Most of these kidney stones can come out by themselves, but if they really can't, there's medicines that they can take, such as alpha antagonists, such as tamsulosin, calcium channel blockers. You can also do more like procedural stuff like nephrolithotomy, which is like removing the stones, laser tripsy, you're breaking the stones into fragments and then letting the patient pee them out, stuff like that. Obviously, you want to increase their fluids to an adequate amount to try to help them flush it out. You want to encourage them, help them with mobility, because it's going to be quite painful for them. They don't really want to walk around, but you got to remind them, like, hey, immobility is also a risk factor for developing these stones, right? And obviously, before you move them, you want to help them manage their pain. You want to give them any medication that's on their schedule to help try to alleviate the pain, right? That's kind of a general nursing concept. Before you move them, you want to pre-medicate them if they're in pain, right? You can strain the urine if there's a doctor's order to send the specimens for lab to see what it's actually made of, so they can get a better idea of what it is. So maybe in the future they'll be like, oh, it's high in citrates, you need to cut down on, energy drinks or whatever, right? I don't know why that did that, sorry. Okay, so management-wise, obviously pains, NSAIDs, opiates. Nifedipine is the calcium channel blocker, and then tamsulosin is the alpha blocker that I mentioned earlier. Allopurinol, this is how I kind of mentioned it's related to gout, because this is decreasing the uric acid level, which can also cause stones to form. And HCTZ, which is decreasing the amount of calcium in the urine. So these are basically anti-spasming agents. So tamsulosin is probably the biggest one, in my opinion, like the highest yield one. And then these ones are decreasing chemical and electrolyte levels, because you're changing like the uric acid or like, the calcium. And obviously pain is very obvious here. So this is a kind of a niche thing. So for those that like to understand a little bit more in depth to help them see the bigger picture, this can be useful. So oxalate is a risk factor for, like, a diet high in oxalates is a risk factor for forming these stones, right? Because calcium oxalate is one of the most common stones. So this oxalate substance is basically found in a lot of these foods that you see on the left here, like nuts, seeds, veggies, fruits, even chocolate and tea, okay? Limiting intake of these foods can be beneficial for people who form these calcium oxalate stones, but it's also like an extra cherry on top if you eat and drink calcium like rich foods such as milk and yogurt with eating these high oxalate foods, because the oxalate and calcium have this relationship where it's more likely to bind, and they do so in the stomach and intestines. So they do that earlier before they get to the kidneys, okay? So it makes it less likely that a kidney stone will form. Again, this is quite in-depth and, pretty niche to know about. It's probably at a deeper level that you need to know for the NCLEX or your school exams, but for me, it kind of helped me like cement the knowledge that calcium oxalate is one of the more common ones, like common stones. So there's some diet changes to be aware of, right? You want to avoid eating these things with gout, because it causes uric acid stones. The body breaks down purine. You can kind of see how this is how it happens, and basically all I'm seeing is that like purine gets turned into uric acid, which leads to these stones, right? So you want to cut down on any of these purine things like alcohol, Coke, seafood, liver, and yeah, the soft drinks is because it has high in fructose corn syrup, and that contributes to uric acid being produced. So once again, dietary changes, you want to make sure they stay hydrated. This is like the good amount, like, the recommended amount. Like we said earlier, limit the foods with the high oxalate unless you're having the calcium with it, right? This is basically what I kind of mentioned earlier with the calcium having this relationship with oxalate. Avoiding salt, like high salt, cutting down on your protein because that's high in those uric acids, like those liver, like the really heavy kind of meats, and avoid extra calcium supplements because too much calcium can cause a calcium stone to form. Lastly, there's several types of urinary catheters. One is urethral, so there's the indwelling, which is like the Foley, and intermittent, which is like a straight cath. Suprapubic, there's several, where they like go through the peritoneum here. and it's a surgical procedure, and it's sutured in place, and the urine just comes out here. And nephrostomies, usually done through the side or the back. Sometimes they can be temporary, and it's sutured in place depending on how long the patient needs them for. It can go for several weeks, several months, but yeah. This is it for this week's video. Next week we're going to continue on arthritis and connective tissue disease, and that should be the last one before we jump back into practice questions. Good luck studying.